we will have Dr. Shefali. She will be talking on functional progression analysis.
To thank AIOS and GSI for giving me this opportunity, I am going to talk on functional progression. It's not moving. Slides are not moving.
Yeah. Okay, Shefali now? Shefali,
Is it with
now.
this?
Just check now.
Yeah. So at this point of time, we have the strategies for glaucoma progression are functional progression. Visual field is the current gold standard not only for diagnosis but also to detect the progression. And other is structural progression. So these are the different strategies for functional progression. Clinical judgment, defect classification, event analysis, and trend analysis, which I will discuss a little bit, and more about the literature available. Coming to the clinical judgment, this is how the overview printout looks. That by simple glancing it, you come to know how your patient is, whether the patient is progressing or stable. However, it has its own sets of limitation because this approach is subjective with high inter-observer variability, and the reported level of agreement among experts also varies. Now, Vishwanathan et al., he studied the inter-observer agreement among the general ophthalmologists, where he asked them to grade the visual fields, and he found the kappa statistics only fair inter-observer agreement, and the K value was, that is kappa statistics was 0.32. Tanna et al., he studied the inter-observer agreement and the intra-observer agreement among the glaucoma specialists who were asked again to categorize the visual fields which were available to them. And he found moderate inter-observer agreement, the kappa was 0.45. However, the intra-observer agreement, that means only when single glaucoma specialist was studying the fields, the kappa agreement was 0.62 to 0.78. This suggests that if the same glaucoma expert is following up the patient single-handedly, clinical judgment may be acceptable. Now, coming to the defect classification, mainly what available is AG score and CGIT score. AGs is based on the total deviation and CGITs is based on the pattern deviation. And Professor Hayal et al., they compared the EMGT scoring system with both these scoring system, that is CGITs and AGs, and reported that both the scoring system has good specificity compared to EMGT, but EMGT identified progression earlier and in more number of patients. Coming to the event analysis, we have GCP and GPA, the guided progression analysis. We are using more, so I'm going to discuss on that. So let's know what is event-based analysis. Is basically we should have two good baseline fields and subsequent fields are compared to this baseline fields. The advantage of this event analysis is that it can pick up the change as early as from the third field, and another thing is that it compares your patient's data to the stable glaucoma patients database, which is already available in the software. So let's see how any point is seen, or machine takes that any point is progressing or not progressing. So Boole, Bengtson, and Professor Hayal, they tested at each and every location the test and retest variability. And so if this is the one second, any point, this is the pointer. So if your patient's, the threshold, if it falls within this, if it is falling within this range of test-retest variability, it is taken as not progressing. If it is falling outside, it is taken as progressing. So if 3 or more points deteriorate in at least 2 consecutive tests, it is taken as a possible progression, and they are highlighted as a half triangle. And if same points are deteriorate in at least 3 consecutive tests, it is taken as a likely progression, and they are marked as this full triangles, dark triangles, this very light. So if you see the sensitivity and specificity, Arnalik, Montiel et al., they look for the sensitivity and specificity if you take possible progression as the endpoint, and he found it to be 93% and 95%. However, Artis and Wu et al., both of them, they found that if you take the possible progression as your endpoint, then the chances of false progression are very high. but if you take the likely progression as your end point, that it increases your specificity drastically. Yeah, this guided progression analysis, it has its advantages, like it looks for the statistical change from the baseline test and whether if this change is persistent. It also takes into account the test-retest variability. It has limitations, like interim test results are not taken into account, and it's dependent upon quality of 2 baseline tests, and it may not identify progression in glaucoma patients with diffuse loss or very advanced loss. Coming to the trend analysis, which is based on the regression analysis, and it needs at least 6 to 7 fields, and one of the important aspects of this is that it gives rate of change over time. So let's see how this VFI summary. Now if you see, once we have 5 or more fields, then you get this VFI slope, and which is plotted against the age, and it also gives you the rate of progression. You can see here there is a rate of, it gives you rate of progression. Another important aspect is that once you come to know that how your patient is progressing. Suppose if no intervention is done at this stage, then how your patient is going to progress over a period of next 5 years. Now the central points are weighted more heavily than those on the periphery in VFI, so that it gives more effective measure of the visual function. See, if this photograph B, you see the number of defects in both are same, but the VFI is 81%, far less compared to the A, because the defects are more centrally located. Now in advanced glaucoma, to detect progression is totally different ball game. You have to rely more on your clinical expertise. You can use 10-2, and if you have glaucoma workstation forum, then you can also get this MD graph slope on, that is which otherwise you don't get on visual field, other normal Humphrey printouts. Now, if you compare the progression on different parameters, which Gardiner et al., he compared the trend analysis of the global indices, and he reported, or he concluded, that the mean deviation detected a larger proportion of patients with progression compared to those the PSD or the VFI. However, he also concluded that no single index, however, was the first to detect every case of progression. Now, Carlos et al., he found a good spatial agreement between the point-wise event-based GPMGT criteria and the trend-based progressor. But what he found was that the degree of agreement between this analysis is dependent on the various factors. Now, if you compare between the event versus trend, then the GPA2, that is the event analysis, detected progression in nearly 16.7% of the eyes more, and nearly 6.8 months earlier than the visual field index. That means event is able to diagnose progression much earlier and in more number of patients compared to the trend analysis. Wu and colleagues also found the similar sensitivity. So Medrios et al., what he did was he integrated both event and the trend analysis, and what he found that since each method provides unique but complementary information, using global trend analysis and point-wise event analysis may improve the detection of glaucoma progression. And if you use the Bayesian method, that is the method of pre-test probability, if you combine along with this, you can increase the performance. So to summarize, white-on-white perimetry is gold standard for diagnosis. Clinical judgment has good accuracy only, but only in the expert's hands. So in Journal of Ophthalmologists, it should be avoided. Event-based analysis can pick up progression as early as in third field, but you must have good, reliable baseline fields, and always change the baseline after significant intervention. Trend-based analysis detect rate of progression of change over time, and if you use the VFI judiciously, then it gives us the idea about the future progression as well. Thank you.